Hi, my name is Rachel Pacyna. I am a fourth year medical student at the University of Chicago Pritzker School of Medicine, and today I will be talking about IgG4 related disease mimicking gynecologic malignancy. IgG4 related disease, or immunoglobulin G4 related disease, is characterized by fibrosis, tumor like nodules, and lymphoid hyperplasia. It is also defined by dense infiltrations of IgG4 positive plasma cells. This disease has been described in many organ systems. However, there are few cases that describe gynecologic involvement, and overall, this disease is highly underrecognized. It's crucial to distinguish IgG4 related disease from gynecologic malignancy because it is treated with steroids and typically has a good treatment response. Today, I will present two cases in which IgG4 related disease mimicked primary uterine and recurrent cervical carcinomas. In our first case, an 81-year-old woman presented with unintentional weight loss and anemia for 8 months. On physical exam, there was a normal pelvic exam. And on imaging, CT showed a 6 by 5 centimeter uterine mass, as well as retroperitoneal and axillary lymphadenopathy. The mass can be seen in Figure 1, Image A here, and some lymphadenopathy can be seen here in Image B. PET also showed increased uptake within the uterine mass, shown in Image C, and hypermetabolic pelvic, inguinal, and axillary lymph nodes, shown in D. Overall, these findings raised concern for uterine malignancy with possible metastasis to adjacent lymph nodes. Biopsies were completed, which all showed no evidence of malignant cells. In terms of this patient's clinical course, she declined definitive diagnosis and treatment with hysterectomy and opted for continual observation. On repeat PET imaging, there was a worsening of her hypermetabolic left pelvic and inguinal lymph nodes, again shown in D. And so the left inguinal lymph node was excised and showed a reactive hyperplasia with IgG4 positive plasma cells and no malignant cells. The pathology is shown in Figure 1, Image E, where there is abundant plasma cells, and Image F, where the plasma cells stained positively for IgG4 expression. Overall, this supported a diagnosis of IgG4 related disease rather than primary uterine carcinoma. The patient was treated with steroids and had a good treatment response. Moving on to case 2, I will describe a 31-year-old woman who presented with postcoital and intermenstrual bleeding for 6 months. On physical exam, there was a normal pelvic exam with a normal appearing cervix. The patient had several diagnostic tests done. Most notable, a cervical biopsy showed invasive, moderately differentiated squamous carcinoma, grade 2 or 3. On imaging, a cervical mass was identified without invasion and no evidence of lymphadenopathy. And on PET imaging, the cervical mass was hypermetabolic, but there were no other hypermetabolic lymph nodes. Of note, there was a left supraclavicular lymph node that was hypermetabolic, but not seen to be clinically significant at that time. This supported a diagnosis of stage 1B2 squamous cell carcinoma of the cervix. The patient was offered definitive treatment with chemoradiation, and after treatment, MRI showed a near complete resolution of the cervical mass. Interestingly, on surveillance, about 5 months later, the patient had an episode of heavy vaginal bleeding and pelvic pain. On physical exam, there was necrotic tissue noted on the pelvic exam, as well as tethering, which was concerning for recurrence. Cervical biopsies, however, showed only inflamed fibromuscular tissue and radiation changes, but no evidence of carcinoma. Repeat PET imaging showed a hypermetabolic mass in the cervical region that had increased in size from prior imaging, as well as hypermetabolic retroperitoneal and iliac lymph nodes. Hypermetabolic mass is shown here in figure 2, image A, as well as some lymph nodes on image B. Overall, these findings were highly concerning for disease recurrence with metastatic spread to lymph nodes. The left supraclavicular lymph node that had increased in size and activity from prior PET imaging was excised, and on pathology showed reactive hyperplasia as well as markedly increased IgG4 positive plasma cells and no carcinoma. That pathology is shown in figure 2, image D, with abundant plasma cells, and image E, where the plasma cells were expressed IgG4 expression. This led to a diagnosis of IgG4 related disease rather than recurrence of cervical carcinoma. The patient was treated with a 3-week course of prednisone, and on 6-month follow-up, PET showed an interval decrease of the size and hypermetabolic activity of the pelvic mass, which is shown in figure 2, image C, which is clearly showing some resolution compared to image A. And now the patient is 3 years out from her treatment and has not had any clinical signs of recurrent malignancy. To summarize, we report 2 cases in which IgG4-related disease mimicked gynecologic malignancy, and in both cases, once the diagnosis was made and the patient was treated with steroids, there was good treatment response. It's important to note that unusual patterns of lymphadenopathy should raise suspicion for systemic disease, including IgG4-related disease, and should be included within the differential diagnosis of advanced gynecologic malignancy. In these cases where there are systemic or nonspecific symptoms, serum inflammatory markers and biopsies may be more efficacious and less morbid than mass excision or hysterectomy, as we saw in case 1. Lastly, PET imaging is an important tool to help determine the extent of organ involvement, guide sites for tissue biopsy, and monitor response to treatment in the setting of IgG4-related disease.